Dr. Dua Amara for her variable health. Let me begin with the patient overview. A 30-year-old prima gravida female patient underwent a cesarean section at term and fundal myomectomy at the same session. The operation was done without complications. She had a post-medical history of resolved DVT at the first trimester and free post-surgical history. Over the first post-operative day, the patient became pyrexic, tachycardic, complaining of abdominal distension and nausea. On examination, a significantly distended tender abdomen was noted. Inflammatory markers were elevated. X-ray abdomen showed colonic dilatation, so the physician requested contrast-enhanced CT abdomen. Let's have a look at the CT. Let's begin with axial post-contrast venous phase. Let's follow the bowel from the colon from the cecum to the rectum. Is there any transition point or obstructing cause? Are there any signs of pneumatosis, bowel wall thickening, or free pneumoperitoneum? Let's have a look at the arterial phase, particularly the aortomesenteric axis. Any thoughts on the potential diagnosis so far? Let's summarize the most important finding. Adequate opacification of aortomesenteric axis, adequate opacification of portomesenteric axis, combined pseudo and true pneumatosis, and how we can differentiate if the air is confined to the inner wall of the colon, ending in gas fluid level, it's a pseudopneumatosis, and it's mostly associated with massive colonic dilatation. But if the air is seen dissecting the colonic wall, it's a true pneumatosis, and it's associated with ischemic changes. Dilatation of the right-sided colon and small bowel loops with no dilatation of the descending and sigmoid colon and no abrupt transition zone. Moderate right pericolonic fat stranding with edematous changes. Areas of mucosal hypoenhancement noted at the cecum, subinvoluted uterus, and free pneumoperitoneum, which are accepted post-operative. So what do you think the diagnosis? The clinical suspicion of mesenteric vascular occlusion is excluded by the adequate opacification of aortomesenteric and portomesenteric axis. Mechanical large bowel obstruction is excluded by the absence of abrupt transition zone. There is only gradual transition point noted at the splenic flexure. Adynamic or paralytic ileus, which is dilatation throughout the whole gut without signs of peritonitis or ischemic changes. So the diagnosis is acute colonic pseudo-obstruction or Auguste syndrome, which is a surgical condition characterized by acute bowel obstruction without mechanical cause. It's believed to be a result of autonomic imbalance, particularly parasympathetic, increased parasympathetic activity and increased sympathetic tone. Although it's a rare post-operative complication, it should always be considered in the differential diagnosis when bowel obstruction is suspected post-operatively. This diagnosis is confirmed intraoperatively as they found right-sided colonic dilatation till the middle transverse colon with gangrenous patches noted at the cecum. Right hemicolectomy and ileocolic anastomosis was done. The pathology specimen revealed focal areas of infarction, ischemic necrosis, and the segment of colon is ganglionic. As we said, Ogilvy's is functional obstruction, not due to structural absence of ganglion cells, as in Hirschsprung disease. This is a diagram showing the symptoms, signs, investigations, and differential diagnosis of Ogilvy syndrome according to its severity, from early stage to progressive pseudo-obstruction up to colonic perforation, which most commonly occur in the cecum according to the law of Laplace. This is an algorithm indicating the management of acute colonic pseudo-obstruction according to its severity. If there is any sign suggesting intestinal ischemia or perforation, it needs urgent surgical intervention. And if not, conservative management. If failed, endoscopic decompression is needed. Similar cases have been reported. So with the increasing numbers of cesarean sections, Ogilvy syndrome will be encountered more frequently in the clinical practice. Ogilvy syndrome is a surgical complication after cesarean delivery, with progression to cecal necrosis being extremely uncommon and only documented in few cases as from Saudi Arabia. Thank you.
Next, دكتورة منى حجازي.